Well, everybody, this is Carter Williams. I'm the host for today's call. We're doing a call on a couple things around COVID, specifically a discussion around the forecasting the scope of the outbreak, and then innovations to reduce the impact. Specifically in that area, we're going to talk about the application of CPAPs, but for all the people that are attending, if any of you raise your hand along the way and towards the back end of the conversation, if you're working on a COVID-related project that you need some help with, we really have sort of a broad network of people on this call. To give you a quick background, I'm CEO of iSelect. iSelect is a venture capital fund. We focus around the areas of agriculture, food, and health. In that process, we get involved with a lot of different kinds of innovations, and we've recently created a .org associated with our effort to help build out networks around innovation on a global basis, and that's called Cressonia. And so to understand what Cressonia is about, I just wanted to give you a background because it's a little obscure, but it relates to Robinson Crusoe. And the notion is Robinson Crusoe is dropped on an island as a castaway and has to address how does he improve where he is. And he can either go try to grab fish by his hands, or he can stop, invest in technology, build a boat, build a net, catch more fish. And it's the principle that innovation often leads to a better social welfare. And as we remember from The Martian, the effort to sort of apply innovation to solve an intractable problem sometimes pays off. In the concept of what we're doing with Cressonia, we're focused along the broad areas of healthcare and agriculture, and have built a very, very, very broad network of people that see problems, working on problems. Sometimes those lead to investments from a venture capital standpoint. Sometimes they lead to just practical application of technology to solve a tough problem. And interestingly, it's a good opportunity with what is going on with COVID and the outbreak to really sort of think through hard problems quickly and use an entrepreneurial mindset to solve tough problems. So I've assembled a discussion today that includes two people I've run into. One, Tom Fiddman, who I've worked with over the years in a relationship both with MIT and the area of system dynamics. But Tom has got a great deal of experience in and around how you model exponential systems and how they grow, and what kind of judgments you can make from that. And he'll both give you a little bit of a background on his work, and we'll open it up for discussion. And then Eugene Scarberry was one of the early innovators in the area of CPAPs. He's not a medical professional, but he's been in and around since the 70s forward in the area of respiratory technology. And he and I got engaged when some folks from DARPA reached out to me looking on how to 3D print a CPAP machine to help address the ventilator problem. And Eugene and I crossed paths, and in the last week have become fast friends. And so there's an opportunity to sort of give you some insight on his perspective as an innovator in that market and things that he's seen, and he's pulling together a discussion group around how to advance treatment, not just with innovations in CPAP machines and NIV type devices, but also in terms of how we might triage and deal with patients in a more effective way as the system gets stressed. And then after that, after each presentation, we've set up some time to have discussion. There's no real limit to this webinar. When you get all exhausted asking questions, that's fine. I think in both cases, Tom and Eugene and I talked about waiting a week to do this to try to get more organized. And so this presentation is sort of put together rapidly. And so it may have a couple broken parts to it. But please, let's challenge the conversation and open it up and have a polite civil conversation to help both Tom and Eugene do a better job on what they're working on, and then others of you may have perspective that they can contribute to. The notion of what we're trying to do with Cressonia is you have entrepreneurs with problems, you have customers with problems, you've got scientists with problems, and by everybody being more familiar with with each of those challenges, sometimes we can find a solution that's a little unexpected. And then certainly at the end of the conversation, after we've had the two formal conversations, there's an opportunity to open up the conversation more broadly. On your webinar, there is a capability to raise your hand, ask questions, chat. It should be visible in the bottom. Anywhere along the way, you can insert those, and we can open up the mics and broaden the conversation. Eva, who's managing this and has pulled this all together for us, is in the background making sure we don't make too many mistakes in this process. With that, are there any initial questions? If so, just sort of post them and maybe we'll dive into Tom first. Tom and I met, Tom, I can't recall exactly when we met, somewhere in the world of MIT days forward, but
yeah.
As a student at MIT, I got very involved and had for a short opportunity the privilege of being a student in a couple classes of Jay Forrester, who used to think about big problems and look at systems and how to apply them to solve them. And the team at Ventana has taken the ball with a lot of that work in terms of looking at big systems and trying to resolve the dynamics of them, and have been serving industry broadly since on those kind of problems. And along the way, Tom and I and the other people at Ventana have met and intersected at various times over many years. And so when I was looking at trying to understand a lot of the data around COVID and the outbreak and such, Tom and I got back connected a little bit on this topic, either through Twitter or something else. I can't remember now. But I thought that he could bring some light to the problem of what the modeling is going on, the modeling and such. And so with that, Tom, I'm prepared to turn it over to you. I also, if you don't mind, just giving a little bit of background on what Jay's original work was in that context. We probably have a lot of people that aren't familiar with that, and he deserves some credit in this process.
Sure. So Jay Forrester, as some of you may know, he was a pretty amazing guy. He invented the first practical digital computer and magnetic core memory. He built a control system to keep a radar dish level on a pitching ship, which was pivotal in the battle for the Pacific in World War II. And then after building a highly successful air defense system for the U.S., he decided there were bigger problems to worry about and transitioned from essentially engineering control systems to modeling social systems and businesses. So he essentially took the toolbox of engineering control and transplanted it to business policy and created a series of models that were sometimes very controversial, like urban dynamics, which suggested that building a lot of low-income housing in places that were job deserts was maybe not a good idea. And also he kicked off the limits to growth work with world dynamics. So pretty amazing guy. So we're working on a lot of different problems, but still using fundamentally a lot of the same toolkit of engineering control system dynamics transplanted into other domains, whether it's fizzy beverages or pharmaceuticals marketing or B2B markets, or in this case, coronavirus. It's all kind of the same mathematics. So that's where I come from. I'm typically climate and energy focused, but I've done a lot of other things, including pharmaceuticals, and I've been on the fringe of epidemiology a number of times in other contexts, but not with infectious diseases. So what I'll try to do here is just give you a flavor of what's going on out there in the modeling world, and I'll show you a live model, and we can talk about that a little bit, and then I'll just speculate a little bit about what that indicates for opportunities for market-driven solutions.
You want me to hand this over to you? I'll change the share over to you, Tom.
That'd be great.
And Tom is in Montana at the far end of the internet. So he may have a couple drops along the way, but he lent his camera to his children, so we're not gonna be able to see him live, but we'll be able to see his
Sorry about that, but it's the times we live in. Let's see, Zoom, there we go. All right, do you have my cover slide?
Do.
Great, okay. Okay, so I'll just briefly introduce models, but I want to get straight to playing with an actual model. There's actually a sort of a whole hierarchy of models that you can use to look at epidemics. At the simple end, you see some kind of extrapolation and curve fitting exercises, which are generally ill-conceived. What you want is something that kind of captures physically how the process works so that it's both easy to map real-world policy concepts into the model and so that you can take advantage of various measurements around the system. So kind of the bread and butter of the epidemiology world is the SEIR model, which stands for susceptible, exposed, infected, recovered. And then there are a lot of extensions you can bolt onto that. You can add age or risk categories to it. You can network a bunch of models representing different cities with a travel network hook up to them. And then really at the opposite end of the spectrum are individual agent models where you represent synthetic people, sometimes millions of them, with all of the different possible states that they have. And that lets you kind of get the most out of the most in terms of a rich representation. But on the other hand, those models are big and harder to build, slower to calibrate, and so on. So there's some trade-offs in terms of where you live in the spectrum. So what I'll show you today is towards the bottom here, it's really an SEIR model with some risk structure disaggregation built into it. And for starters, I thought we could simulate the guidance that came out from CDC in the White House today, just as an example. So let me show you the model and then we can try this out and see what it does. So just to orient you, current guidance is stay home if you're sick, stay home if you're at risk because of age or a serious underlying health condition, or if somebody in your home tested positive. And that leaves some gaps. So for example, if you don't feel sick, you might still be infected. If you're not in an at-risk population, you might still be infectious. So we'll see what that does. So I'm going to shift over to our modeling software package. Carter mentioned this would be a little rough and ready. What I'm showing you is our model development system, which is graphical, but also kind of nerdy. So you're seeing the real thing here. And probably if you've been reading the New York Times or other sources, you've seen some online COVID epidemic simulators embedded in those pages. This is similar, but we have a little bit more access to the inside of the model. So here's the basic setup. These boxes are accumulations or stocks of people in various states. So you have the susceptible people, the exposed people who are infectious but don't have symptoms yet, then the infectious ones who have symptoms, then the ones who are really sick. Some of them recover and a few of them die. So that's the chain of people states, and then the rest of the model is about what governs the conditions here. So the key process is this red one here, which says that infectious people, whether they have symptoms or not, are out there active in the population. They're meeting with other people and they're infecting them. That creates more exposed people. After a delay, they become infectious themselves and the cycle repeats. So this is the vicious cycle that drives infection. And unfortunately, with coronavirus, it's pretty powerful, which is why we're seeing growth at 30% a day in many locations. So then there are some responses that control it, which are generally the green here. So one is that as you start to see a lot of cases, the public health system mobilizes, they start quarantining people, and that reduces the number of active infectious. So that's one attempt to shut down this red loop here. And the other is that as the disease spreads, you get social mobilization. People lower their behavioral risk through hand washing, through social distancing, and closures of businesses and schools. And it seems like practically every other institution that can't be eaten these days. And all of those things are lowering the transmission rate of the disease. That's the other way to shut it down. Then there are a couple of things that you really want to avoid. So one is overloading the system with sick people. You have a lot of serious cases requiring hospitalization or ventilation. That puts strain on the hospital system, and when it's overloaded, the fatality rate goes up. So you wind up with more people in the deaths box instead of the recovered box. Another is that as you start to have a lot of infected people around, the caseload for the public health system, which is trying to track down the contacts of these infected people and get them isolated so they don't infect more people, they get overloaded as well. And that means the effectiveness of quarantine goes down. Third one that's not shown here is as you start to have a lot of infectious people around, they're a danger to your healthcare workers. And another is that as you're operating in a socially distant environment, that the economy takes a big hit. As those costs accumulate, people develop adherence fatigue, and the social mobilization you need to support these measures goes down. So your ability to sustain social distancing does not stretch on indefinitely into the future. And of course, as soon as you remove your policies, the disease can come roaring back, as happened in a lot of cities in 1918. Okay, so at the moment, you'll see some graphs here. These are showing an uncontrolled epidemic, and this is a pretty bad scenario, a bit like the Imperial College scenario that came out last week, where they simulated the UK and the US with 2.2 million deaths for the US. Part of the reason that's such a bad scenario, well, it's partly simply that the number of infected and sick people explodes in an uncontrolled manner. And it's also that because the hospitals get overloaded and therefore, let me let's just switch to the high risk population here. And therefore, this is the fatality rate. You see this bump here in fatalities. That's due to the fact that people who need a ventilator can't get one, for example. So what could we do to control this? I've made a simplified control panel here that looks at some policies, so we can fire this up. And I just need to move a Zoom window that's in the way here, or type blind. So let's try those White House guidelines. Okay, so I'm running the model live. And you see a red line on the charts here now. So I'm showing hospital strain and total number of deaths. So the White House guideline is saying, okay, we're going to reduce risk by getting people to stay home. That has a big effect, except that we're not going to do it for people who are low risk. So they're going to go about their business as usual. Assuming that dramatically dilutes the effect. So we've made the epidemic a little bit later and lowered the strain on the hospitals quite a bit, but certainly it's still a pretty catastrophic outcome. There are potentially other things that would be in the mix, like quarantine, but as long as the public health system is overwhelmed by a large caseload, which is what's happening here, that's actually a very low leverage policy. You probably over the web can't even see the slight changes in the curves that are happening here. If you, and again, part of the problem there is that that's another part of the system that doesn't scale very well. So it works fine when, one person per 1,000 is infected, but not when 10% of the population is infected. If you can get people to self-isolate, that helps too, so that getting the sick people out of the system makes a big difference.
Does that, Tom, on that one, does that also mean self-isolate even from their family?
In the model, yeah, in the way this is set up, it does. But of course, that's potentially difficult to achieve. And all of these things are only partially effective here, in part because of the lags in this chain. So you have, even if you have people who feel sick self-isolating, that takes care of the infectious symptomatic box, but you still have the asymptomatics. So one of the things that we're sorely missing at present is effective testing that would enable these things to work better. If these people knew who they were, then you can quarantine a portion of the population instead of everybody. So that's the setup. And of course, this is maybe a little bit pessimistic, but it is possible if we get good testing and we get the low risk population on board and get them to isolate, we can actually extinguish the epidemic, or at least keep it at an extremely low level. But then, of course, you want to, some people are asking, well, is this actually worth it? Or should we just let it rip? And, that comes from a mix of sort of failure to appreciate the magnitude of the problem, the 1 or 2 million deaths you could easily be facing, and genuine concern for economic trade-offs, because certainly an economic catastrophe is not free. That has knock-on health effects on vulnerable people in other ways. So we actually have, I mean, it's in a way ghoulish, but we've built a bit of a cost-benefit structure into this model to look at what's the cost of mortality, what's the cost of infections in terms of medical care and lost labor productivity, and what's the cost of the mitigation measures that you're taking to socially distance people that are there to get that curve down. And as soon as you start thinking about that, you need to start thinking about things in terms of risk and uncertainty, because there are lots of pretty deep uncertainties here. It's not just uncertainty about how the disease will progress absent intervention. There's also a lot of uncertainty about how much hospital capacity we really have or we can create, about how people are going to behave in these totally novel circumstances, and about the economic impacts. So just as an example, if you look at social distancing, and I should be in the real thing here. If you look at social distancing, there's some level of normal social interaction that gives you a normal economy. That's the green dot. And if you say, okay, we're going to have no social interaction at all, we're all back to being hermits in caves, then you have nearly no economic activity. You have no division of labor, you have no trade, no nothing. Somewhere between those is a curve that connects those, but I think we really at present have no idea what the shape of this curve is, and that makes it very hard to make a good trade-off between social distancing that wipes out the infection and the economic side effects of doing that, both in terms of loss of life and other things. But nevertheless, I took a stab at that in this model. So we can run that scenario if I can get Zoom out of the way here. So I'm just going to run a controlled risk scenario. I'll start from the uncontrolled worst case. And instead of looking at single model runs, I'm going to look at hundreds of model runs with different random draws of disease properties and whether we're going to get relief in the summer as high temperatures make it harder to the virus survives, how compliant people are, how much hospital capacity we have, and a number of other things that are uncertain about this system. So now you can start to look at, okay, if we reduce behavioral risk by social distancing and hand washing by 85%, what does that do? And the curves just rescale, but you'll notice we're already below 1 million deaths expected value. That's still pretty terrible, but it's progress. If we can have effective quarantine, that's progress too. If we can get people to self-isolate. Each of these, now that made a big difference. So that's self-isolation. We're down to 250,000. It's still costing the economy about $2 trillion, which is a mix of mortality and mitigation costs. And we can keep going here and look at what happens if we get the low risk engaged in these policies. And this is still pretty immature, but it's interesting. I discovered there's a real game changer here, which is the ability to isolate people before they have symptoms. So if I crank that up, you'll see a sudden transition in the behavior. We're now down to a flu size problem. There's still some outlier runs with 500,000 deaths, but actually the expectation now is more the size of the flu, maybe 50,000 deaths. So that makes a huge difference. So the takeaway here is not so much, go ahead.
Can you restate that case again? That is.
So the game changer here was the ability to isolate people who don't have symptoms. And I think the takeaway here is not so much that's what we should all run out and be doing. But the reason that works in the model is that it then lets you socially distance 5% of the population instead of socially distancing 100% of the population. And that's the transition that South Korea and China are trying to make through really extensive testing. And we just aren't there yet. But there may be some technology
That's
policy.
socially distanced, asymptomatic that have been tested to have the antigen or something.
Right, exactly. So that's figure out who's got it, even though they don't know they have it, and incentivize them to stay isolated one way or another, so that they're not infecting the rest of us. And you can do that at a vastly reduced cost to the economy. I mean, you could probably afford to pay them, just say, hey, we'll give you $10,000 a month to stay in this box.
Yeah.
So I think the takeaway here, this model's still too immature, and these sensitivity runs too untested to say for sure. But the key is that you can use models as a tool for identifying these high leverage policies and deciding whether on a risk adjusted basis the package of or the portfolio of policies you're pursuing is going to get the job done or not, and at what cost. So just from playing around with this, I think there are a number of interesting opportunities that are suggested by the model. I mean, obviously a vaccine or an effective treatment is kind of the holy grail. That has clear value, but there are a bunch of others that are important that can change the game in this model. One is the ability to provide standby capacity to deal with an epidemic in between epidemics, so you don't kind of lose the thought and fire the pandemic response team 2 years before the pandemic happens. So, the hard part there is that you have to maintain capacity to respond that is unused most of the time, and that's inefficient, and economies tend to try to get rid of inefficiency. So if we could figure out cheaper ways to do that, that's helpful. Just having a better early warning system and rapid responses gives you a lot more time to think, and there's a lot of option value to that. The game changer we were looking at a minute ago was better detection and isolation of limited subsets of the population. And then finally, to the extent that a certain amount of runaway epidemic is going to occur before you get it in control, anything you can do to rapidly increase the capacity to provide protective gear, ventilators, beds, public health, contact tracing ability, and all those things, and ramp that up really fast has a huge welfare benefit for the people at risk who do get really sick. So there's a big agenda here, but lots of opportunities to do well by doing good.
Tom, we have a few questions coming in through chat.
Great.
Can you put them on live to ask their question? Or is that possible? Or
Sure. Let's start with Sarah. Sarah, if you want to ask your question out loud, you are open. She says, this model is just the U.S., right? Any reason to think the U.S. will or won't be drastically different than other developed countries, or will this model apply?
Yeah, good question. I think there's certainly differences, but they're probably mostly on the response side. The way the disease unfolds in the population in the early epidemic seems to be pretty similar in most places. So I think we can learn by looking at others. Unfortunately, there aren't that many really good examples of success to copy, and it's not always clear exactly what it was that they did that was the secret sauce. So to some extent, we need to work this out for ourselves.
But you've in some of your analysis, you've found some variations in R naught.
Yes, and of course, South Korea and China have apparently really stopped it. And then the question is, how successful will they be in the transition to relaxing the social controls and driving the suppression of the disease through extensive testing and tracing. Seems to be happening, but it may be a little too soon to tell whether there will be a resurgence there, and this is sort of a, you know, like a forest fire that keeps sparking up other little fires in related locations.
And is there sort of on the early warning sign, do you have a sense as to how early you need the warning sign that it's going to depart? Like, do you need to know in November to prevent a major outbreak in the United States?
Well, I mean, that certainly would have been nice, but actually we probably had a fair amount of early warning. It was just hard to get the system ramped up to start responding and taking it seriously. And, you know, partly that there's sort of a Cassandra's curse of a big potential pandemic crops up, modelers look at it, raise the alarm, then there's a big public health response, the pandemic doesn't materialize, and that could either be because the response worked, or it could be that the models were wrong. And it's easy to get it wrong because the early signals are unclear. So, you know there's a pandemic potential, but you're not that certain that it's really going to take off. So you somehow got to change the decision makers' mindset about how to respond to these things so that they don't start to think, oh, well, you cried wolf 3 times, we're not going to do anything the 4th time.
Hey, Tom, Sarah here again, what's the feedback loop like right now between the modeling community and actual policymakers? Like, is there an increased interest in this kind of work and listening to it, or has that not really changed?
There's definitely a lot of interest. You know, of course, with it growing 30% a day, which is just nuts. I've never experienced anything that did that for any length of time. There's a lot of chaos, but we're working with one state already on building a kind of an online continuous forecasting capability, and that will let them do resource allocation to the response geographically in the state. And I think there are a lot of other things like that underway. So that's an encouraging sign.
Great, thanks.
Next, we have Paul Olivo with a comment or question.
Hi, nice talk. This is Paul Olivo, and I have a background in IVDs, and there's been a huge amount of discussion about the issue of developing capacity for testing, but I have not seen a lot of discussion about the quality of the tests. And I'm particularly concerned about the sensitivity of the test, because I've heard as low as 70%, which is generally not what one thinks of when one thinks about molecular testing. And that's because the quality of the test is only as good as the sample. And there hasn't been a real clarity on what's the right sample. And I see a lot of poor sample collection, et cetera. And does your model take into account sensitivity of the test? Because if it's as low as 60%, which I've seen in some cases, that would really affect your model.
Absolutely. And I guess that problem is wrapped up. Actually, I'm glad you brought that up, because I wasn't aware of the sensitivity problem per se, but there are other test problems around availability and how have the criteria for who gets tested changed over time and so on, which means that there are a bunch of unknown biases in the data. You know, so on the one hand, you have a big expansion of testing that gives you the impression that the disease might be going faster than you thought, but on the other hand, the disease is probably growing faster than the testing capacity. So it could actually be that the sampling of infected people is decreasing. So it's pretty hard to know what's going on that front. A couple of colleagues like Kazir Ramandad at MIT have done a lot more work on representing the testing and reporting system in order to try and back out from the flawed data what might really be going on in the underlying population.
Right. Thank you.
Hey, Paul, my understanding the sensitivity issue was part of the reason why there was a delay in FDA, that they were concerned that the WHO tests and other tests had problems. Is that true? Does that matter? You have a public
Well,
policy perspective?
I don't think the CDC, the problem was that the CDC did not, it was a little bit of hubris. They assumed that they could make a better test than WHO. It wasn't because they had knowledge that the WHO test was flawed in any way. And then the first test the CDC made, the problem there actually was specificity. There was some false positive problems related to the primers. But to me, the bigger issue is once they got that under control and private industry got involved in making their tests, molecular tests generally, under ideal circumstances, have very, very high sensitivity compared to point of care and antigen testing. The problem has always been, and this is true with flu and RSV, is the samples quality and the collection process is not uniform, it's not reliable. And with a new virus, you don't know what the best sample is. I've heard of cases of negative upper respiratory swabs, nasal pharyngeal swabs, and a positive BAL, of bronchoalveolar lavage in a patient with pneumonia. So we know that we're not in the 90s in terms of sensitivity.
Yeah. Okay, thanks.
Next, we have a question from Craig Mansky. Craig, you can.
Hi, Tom. Great presentation. Couple of quick
Thanks.
questions, and maybe you answered a portion of these or some of these already, but what percentage death rate is your model using?
It's using 0.6%, which is at the low end of observations, but it's close to what's thought to be the kind of the case fatality rate that you settle out at when you've had time for the reporting lags to play out. That's what happened in South Korea, and I think it's also the Diamond Princess was in the same range.
Yeah.
Yeah, because I think it was talking.
But then there's a multiplier in the model which says that fatalities go up if the hospital system's overloaded, which is evidently what happened in Italy. So, Italy had two problems. One was an aging population, which means just a bigger high risk category, and the other being the overload problem.
And then you mentioned asymptomatics. What percentage is the model assuming are asymptomatic of those who have gotten the disease? Because that would seem to me to be a very important variable in this model.
Yeah, it is. In here, I used a estimate from the Lancet article that came out last week, kind of summarizing a lot of the disease parameters, which was 80% asymptomatic. Interestingly, in the short run, it actually doesn't really matter because if there are a lot more asymptomatics out there, then the death rate would have to be adjusted to account for that. So the short run trajectory of growth and deaths is the same, but it does have a big impact on how big the peak or the endpoint is, because if there are lots of asymptomatics, then you have a big chunk of the population that's at least not at risk of death, which would be nice.
And finally,
but of course, there's a flip side to that, which pertains to a question somebody else asked here, which is if you have all these asymptomatics running around, then your control problem is harder because especially absent good testing, you can't find them and isolate them. So you have to isolate everybody. But please
Finally,
go ahead.
how important do you think it is to know who has had the virus and is beyond the symptom stage and infectious stage?
I'd say that's a pretty interesting question, because it then tells you, you know, are you 1% of the way into it, or are you over the hump? So that's kind of an important number. It also, of course, matters whether people quickly lose their immunity or not. If they quickly lose it, then we really just need a vaccine, or this is just going to be an annual event.
Great, thanks.
Next, we have a question from Robert Gish.
Greetings, everybody. Thanks for the wonderful presentation. I'm a transplant hepatologist that's on the faculty of a number of universities on the West Coast, including UCSD, and I'm involved with a number of global efforts, as well as monitoring transplant websites around the world and national blogs, a number of nonprofits as well. I wanted to make one comment before I ask my question, which has to do with test sensitivity and specificity, because I've been very involved with an EUA submission this last week for a rapid test or point of care test looking for serology for coronavirus, and that's pretty far along, but more to come on that later. Test sensitivity for PCR for disease state is best looked at with bronchoalveolar lavage, and we in the hepatology and transplant community really think that that test sensitivity is in the 93% range. And if you match it up with a CT scan and then retesting, it's probably even higher. Nasopharyngeals in the 73% range, maybe as low as 67%, and nasal or oral pharyngeals far less than 50%. And as you heard before, it has to do with quality. Second comment is there's no evidence of immunity to this virus yet. There are some data on very small studies in humans and one primate model of neutralizing antibodies, but whether those are protective or not has not been documented. So using the word immunity is going to be very difficult for the near term until we have more evidence of that. And then moving to my question, there was modeling from the 1919, I call it the 1918, 1919 flu, that the communities such as Seattle, which had very or much stricter social isolation, and there's 2 or 3 other cities that paralleled Seattle, and then there's the flip side of cities like Boston, who were terrible, late, and very poor at social isolation. They didn't use the term then, but we'll use that concurrently. That the economic rebound was much faster in those cities who had high, fast, strict implementation, which is the converse of some of the statements that have been made over the last few weeks about trying to, open again by Easter. I wonder if you could include that in not just a cross-sectional model or near-term model, but long-term model. Thank you.
That's for sure. So I'm just running a sensitivity simulation for the uncontrolled case while I'm talking. But, again, my analysis of this isn't too mature, but I spent some time looking at what's the trade-off in total cost between essentially mortality and mitigation, which are the dominant components. And here I'm actually using a statistical value of life, which is $1 million, which is about 1/10 of what that's really thought to be on average. If it's $10 million, then this is a $20 trillion problem. But of course, we don't really have 20 trillion to spend this year. So anyway, that's a long discussion. But if you look at the outcomes, I'm just going to give you the distribution of outcomes, if I can here. Look at the mean. Oh, yeah, okay. I didn't have all the settings in place to do that. But if you look at the outcome in terms of the distribution of cumulative costs over the coming year for an uncontrolled epidemic or a back to work by Easter scenario, which would basically mean the epidemic comes back in May, a heavily controlled scenario, even though it's extremely expensive, is a far better outcome. By several $1 trillion. So I'd say the model agrees that this situation is analogous to the 1918 flu in that respect.
Thank you.
And actually, yeah, sorry. So I didn't manage to show the distribution, but if you just look at the uncontrolled line here versus in blue versus the red, we're talking about a difference of $1.5 or $2 trillion over the year. So the full control scenario is just better. Primarily because even though you take a big economic hit, you have 2 million people alive at the end of the year who wouldn't be otherwise.
Next, we're going to open it up to Bruce German for his question.
Hi, and congratulations. This is just magnificent stuff. Thanks a lot for doing this. I just had a quick question. It seems like, and I'm impressed that knowing who has the flu or the virus seems to be everything. So could you imagine that we would have a faster triage system that would identify people, their body temperatures going up slightly or that kind of thing, that we could deploy much wider and then use that as a triage to get people into the accurate testing? How might that play out in your model? Is it worth the investment or no?
I guess the anything that would sort of improve the function of this loop that's trying to isolate or quarantine the infectious people has a gigantic payoff in terms of value to society. So I'm given I just can't imagine the cost of deploying such a thing would be anywhere near $1 trillion. So so even though it might be expensive, it's sort of a no-brainer, and I think there are probably a lot of policies like that. In terms of is what we need an app or a smart thermometer or something else? I don't really have an opinion about that on the basis of the model, but it seems like a target-rich environment for successful interventions.
Health has been doing this for a few years, and they're pretty accurate just with simple temperature device that plugs into your phone.
There's the Kinsa smart thermometer thing,
right?
Yeah, and their data is interesting. It shows big decline in anomalous fevers in places that have had a lot of social distancing in the last week or two.
Yeah, I'm impressed with. I'm a chemist, so measuring seems like a good idea to me. But
yeah,
I'm impressed it's working the other way.
Well, and Bruce, this is one thing I've been sort of pondering is what's your event horizon, and do you want span-wise data? There's interesting stuff coming out of that guy NextStrain, or is it NextStrain, or he's been sequencing this and trying to understand the legacy of it. But if you sort of set yourself in November and said, what data might I want to gather in November to affect a better policy decision so that you could take the uncertainty out? And if you were to monitor the general population around influenza and contact tracing and had the sort of a graph database around how this kind of stuff propagates, and if it's a model that's really an agent-based model that better tells you what to do, if you build the agent-based graph database and some of those behaviors off of other diseases on a regular basis, would it would it reduce the policy uncertainty in November?
Right. I mean, in principle, a model should do that. It should let you integrate diverse data streams and filter them so that you have a sense of the true state of the system. That's kind of the goal. And there are some models out there that are a lot better than this one, that have, you know, the agent-based dynamics and detailed travel matrices and just a lot more data brought to bear on them. Somehow the loop didn't get closed from those models to policy. And I don't know if the failure was in the decision making or in the communication of model results or in the feed of surveillance data into the models or what. But
Who runs those models?
Well, let's see. There's an annual flu forecasting competition run by the CDC, for example, and a dozen or 20 groups participate in that every year. So one of the big players is Los Alamos National Lab. They have one of the big models. Presumably the others we've been hearing from, Imperial College and so on, are also in that game, but I don't remember the specifics.
Thanks, Bruce.
We have a question from Richard Miller.
Good afternoon. Thanks for hosting this, Carter, and great work, Tom. A lot of my associates, we're having conversations daily right now on the problem with supply channels and resources and forecasting and burn rates, specifically to the PPE. So we're looking at what you're doing. Can we integrate the same model that you're using on a national basis and specifically focus on the hot zones to slow the aggressive growth that's happening, like in New York City or Philadelphia or some of the other areas, and integrate that into the burn rate and what we need to do to deploy, PPE and other resources to slow the growth, specifically in that hot zone, and deploy what's not being used in other areas to assist in that model.
Right. I think that's a good instinct. And actually, I built a similar version of this that was disaggregated by a region to help a friend look at the question of whether Switzerland should close the border with Italy, because there are a lot of day commuters over the border from northern Italy into Ticino. So it totally works to add spatial detail to the model with people flows across boundaries and differential penetration of the epidemic in different places. And that would let you kind of geographically prioritize your resources. And actually there's another class of models that would also be useful here, which would be around sort of building out this part of the system, looking at exactly what are the components of delivering hospital care and what are the supply chains that deliver those, and then making sure that infections or lockdowns elsewhere don't disrupt those supply chains and so on. So there's a lot of logistics modeling that should be happening here in parallel with the epidemic models. I guess, again, the problem is it's happening so fast. We're a little constrained by the tools that are ready to go. And so to some extent, we're going to learn here for next time. And hopefully next time will be a ways off.
Sure. Well, that's certainly a big issue. One of the things that we're finding in the hospital industry, especially in the supply chain, as well as the CDC and is the lack of communication with pertinent information, because everybody's maxed out.
Yeah.
So it's not flowing smoothly. So we're looking at other industries that are stagnant right now to come in with their off-the-shelf type things and improve the communications on behalf of everybody so we can give decision makers instant access to suggestions, as well as vet out what the supply chain is and put that into the burn rate, especially with PPE, and try and alleviate scammers and misrepresented products that aren't really effective on the front line. So there's
Right.
an awful lot of things happening right now that we hope that we can, assist.
And the funny thing is that kind of takes you back to the origins of system dynamics, which was supply chain models. The first book Jay Forrester wrote was Industrial Dynamics, which led to the beer game, which is a supply chain model. And it demonstrates a lot of the problems we're seeing here of hoarding and phantom ordering and just general chaos in supply chains from uncoordinated information and disruptions at unpredicted points in the system.
Yep, social network analytical tools are trying to be implemented.
Yeah.
Very good, thank you.
Next, we're going to open it up to Matthew Bradley, and we'd like to ask people asking a question to briefly say what your affiliation is.
Hi, my name is Matt Bradley, and I guess in terms of affiliation, I went to high school with Carter, and we've kept in touch over the years. I actually work on production lines. I build production lines for a variety of industries, everything from companies you've never heard of to large companies that you have. And what I'm wondering is, this model that you presented was very fascinating. And I'm wondering how long it's going to take to converge to an actual solution, that reflects what's actually happening. And as I was thinking about it now, you were just talking about the differences in geography and so forth. And some of these parameters may vary with time as well. For example, the social isolation, it might be one value today and another value tomorrow. And if you can adjust your model to take that into account.
Right, and actually in this model, it does vary over time. So people are adjusting their behavior. Well, risk isn't too controlled here, but on the red line, they're adjusting their behavior in response to signals from how much disease is out there, and also how fatigued they are from being isolated and running out of cash and problems like that.
Mm-hmm.
So the next step, what we'd like to be able to do is measure those things, so partly you can, if you put a state under lockdown like California, you can then observe the infection rate after that. And what you hope to see is new infections peak and start to fall at some point. But of course, there are lags in the system from this long chain of between infection and onset of symptoms. So that can be hard to see. And that's confounded by data problems in the reporting system. So it would be cool to have other ways to measure behavior as well, from which you could infer what's really going on the ground. But we definitely want to close those loops and start incorporating those measurements in the model so that we can get sort of early feedback on whether it's working or not.
Okay, so how long do you think that'll take?
Well, I think
Just
we'll
roughly,
have,
it's gonna be hard to say.
I think we'll have a preliminary version in a couple weeks. That's what we're trying to do. And the order of magnitude of these delays is a week to 2 weeks as well, kind of in this part of the system.
Thank you. Thank you.
Thank you.
Next, we have Joseph Namath. Joe is asking, is there any modeling around an echo wave of infection before vaccines are developed?
Yeah, this model will definitely do that. If you, I don't know if I can make an echo here quickly. So if I say that, actually this is kind of relevant to the back to work. So if we have really strong behavior change and start, say, day 30, and let's see, we start on day 30, but we end on day 60. So we basically take a break for a month. Here's the number of infections. So you can see a sort of a two-hump camel here. So the disease is going like crazy, then a big behavioral invention shuts it down, it starts to fall off. But as soon as you lift the sort of the social sanctions, it comes back. So that's the echo effect. And I think some of the other groups have looked at that as well, like the Imperial College study recently had also a kind of a control strategy, which was to let the disease come back in a series of small waves so that you stayed below healthcare capacity, but you kind of let the whole population ooze through the system slowly. And that still gives you a lot of deaths.
Yeah, does that mean you can't change the area under the curve? You can just change its shape? Ultimately, no matter what policy you take, you're going to end up with the same amount of people that get it?
It does change the area under the curve a little bit. So for example, if you look at this graph at the left here, the number of susceptibles. So with the echo policy, the blue line here, you end up with fewer cumulative infections over the entire period, but it's still a lot. What would be better is if we could keep a lid on it until we have a vaccine or an effective treatment.
That a vaccine rather than herd immunity is I guess it all depends on the degree that immunity persists.
Right. Yeah. So a vaccine gives you herd immunity without to infect millions of people, which entails risk of death to 1% of those people. Yeah. So that's obviously more attractive if we can get it. Yeah. And then of course, somebody raised this point earlier. We don't actually know how long immunity lasts. If you have, if the system's doing this, if it's taking recovered people and turning them back into susceptible people,
you're screwed.
That's pretty unfortunate. So I guess I left that loop out of the model.
Let's not put that loop in yet.
Yeah, I'm an optimist. But I think we need to really consider that possibility.
But another, could you put people who are resolved in amongst other people to actually stop the progression? I guess if you don't have vaccine.
Oh, you mean are these people a danger to?
No. Put them in as a way to slow it down. If you don't have a vaccine and you have recovered people who have herd immunity, actively stick them in.
Oh, right.
Like they are, and actively have them in food service or put them into the hospitals or in some way actively.
Right. That's an interesting thought. We had
it's a random thought.
Explored that. Yeah.
Let's cruise through some more here because I think we've still got about 5 people.
Next we have Robert Feldman.
Hi, can you hear me?
Yep.
Hey, Tom, great work. Carter, thanks for the invite. I'm with a company called Prime Genomics, and we're developing breast cancer diagnostics tests. So a little bit ancillary to what you're doing here in modeling, and we've been talking with Carter, and I think Paul is on this call too, getting to know each other a little bit. I come from a heavy genomics technology background, development and applications, and a lot of population genetics. So I tend to think about these questions in terms of the populations and how they interact with each other. And what I'm wondering is, does your model take into account the regional differences in, one, the timing of these social distancing measures, and also the sort of compliance that we're seeing and the differences in compliances between regions, and how that might affect ultimately the metrics that you're looking at, the mortality and the transmission rates?
Right. This version does not. I have another version that has some geography in it, but honestly, we haven't explored that very much. Some of the big agent modeling groups or the networked SEIR models have done a lot of analysis on that, looking at timing of interventions in different places and whether border controls are effective and things like that. I think the one universal insight is that border controls are effective under only a very narrow set of circumstances. They buy you time by keeping the fire from taking hold, but once you have community spread within your boundaries, you need to look at other policies. But I think there's a lot to it, and that's a big challenge for the US, where we have open internal borders and huge diversity in state policies and a lot of mobility of people. I don't have the answer there, but it's certainly going to be an interesting social experiment in the sense of the Chinese curse of may you live in interesting times, as Eugene brought up a little earlier.
Yeah, great. I appreciate the input. I'm just wondering, how big of a factor do you think it is at this point? The virus is probably everywhere, right? But we're still undergoing these containment measures to try to keep the spread down within our local regions, and of course, national, international travel shut down completely. I guess the question really is, how effective are those measures, and in terms of how they move the curves, right? Once we're already at the place that we are. And I guess it has to do with the timing, right, and flattening out the curve, as everyone has been talking about, right?
My mental model says that those controls are not that important now. And, so I live in a county of 100,000 people, and we only have 40 cases, although, growing 100% every 3 days, like everywhere else. But, we can imagine that our public health system and our hospital system can still keep a lid on things a little longer. Tourism is completely shut down when we're normally a big tourist destination. So I think we're actually not getting bombarded from the outside all that strongly. So I guess my mental model is that the community spread is the problem we need to be paying attention to, but I guess I'm hesitant to make too strong a statement, because whenever I say things that I haven't actually run in the model, I get burned.
Yeah, no, fair enough. Locally, I live in Santa Cruz, and they've taken measures in the last 2 days to close the parking at the beaches because people were coming over from San Jose and from Silicon Valley, and not necessarily treating the social distancing in the way it's intended to be treated. So
right, yeah, and so for us, it's a mixed bag, because our hotels are empty, the airport is empty, so that reduces the kind of the external burden. And the other thing that's happened that's surprising is the hospitals have been unloaded, because suddenly you don't have tourists around getting gored by bison and falling into hot springs and things like that. But then the flip side is there's evidence that people are coming here to hide out. So they're frantically trying to find an Airbnb in Montana because they perceive it as safe, when in fact it probably really just, we're 10 days behind some of the worst afflicted places. So without social distancing, you don't get much time by migrating around. Plus, you expose yourself to risks along the way. So,
Right. Great. Well, thanks. Keep up the great work, Tom.
thanks.
Mark Saller, we're opening up to you next.
Hey, good afternoon, everyone. Tom, fantastic presentation here. I've known Carter for, 10 or 20 years, and I currently do infrastructure development in Sudan, South Sudan, and Sub-Saharan Africa, specifically focusing in infrastructure and agriculture development. So here's my question, a couple questions. I sent a chat to everybody, just kind of giving you a heads up on something China is doing. My son works in Shanghai. He left a month and a half ago just to kind of get out of town and spent a month and a half here. And he just returned 2 days ago. And he teaches and works there at a local high school, teaches history. While he was gone, and the whole time he was there, and he's in Shanghai, which is 20 or 30 million, and it's about 500 miles from Wuhan in Hubei province. It's like from, anyway, you get the picture. They took the temperature of everybody, bar none, every single day. And whenever you left your apartment, you had to wear a mask, and they provided them. And whenever you entered any building, they took your temperature. So if you wanted to walk around outside all day, I guess you could. But they really did a lot with collective monitoring of everybody's temperature. And I think it was Bruce that brought that up. I think doing it haphazardly is somewhat of a waste of time, but doing it for everybody, I think you're onto something. And if we could nudge policy with technology and nudge technology with policy, I think that would be extremely useful, especially for this sort of modeling. So I just wanted to kind of throw that out there and concur with Bruce on that. Question I have for you guys, though, is do we know what the mortality rate might be without these respirators? I know we focus a whole lot on healthcare and on the beds and on intensive care. And I'm not trying to be heartless or anything like that, but I do wonder, since people who are already ill in general are getting the disease, suffering from it, and dying from it, I'm wondering, have we actually done some work to see how many of those people were kind of dying anyway, and this was that final straw? And more importantly, if someone like me gets it, and I'm a little bit older than Carter, I'm 60, but I'm in excellent health. If someone like me gets it and I get really sick, 1,000 people like me get it and we're really sick, and we don't have any respirator, how does that compare with 1,000 people like me getting it and having a respirator? So this is getting a little bit into the more of the current policy debate, but some of your screens did show public cost and so forth. And I thought I'd bring that up to tie into the great work you're doing here. Thanks, Tom.
Right. First, just a comment on the thermometer thing. I think that's in the general class of problems that are of solutions that are trying to say, okay, let's figure out who the infectious people are and isolate them. And that's going to be a small fraction of the population. So it's sort of activating these loops down here, as opposed to the policies up here, which say, we don't know who's got it, so we need to, and that has a huge social cost, So we just gave everybody $2 trillion to mitigate the side effects of this kind of social distancing loop. $2 trillion would buy an awful lot of thermometers. I don't know that they're sort of selective enough and so on to solve the problem all by themselves, but I think that's indicative of the kind of the scale difference between the top half and the bottom half of this. You be more selective or surgical about your approach to control, it has a huge payoff. I guess, part of our challenge right now is we don't know what's going on, and it takes time to ramp up the supply chains for all these things. So we really need this to buy time to figure out what the heck we're going to do next, but we can't be 100% socially distant forever. We've got to get these other parts of the system scaled up more. And I'm not convinced that kind of the CDC plus the states and other leadership is really on top of that. I think it may be a problem that nobody wholly owns, and therefore is not getting solved from
The social mobilization problem.
Well, not just the social mobilization problem, but also the massive scale up of testing and contact tracing and things like that, which which Korea and China have implemented. We don't seem to be there yet, but that's what we should be doing with the time we're buying ourselves through the social mobilization.
Yeah, and this is sort of it's a little obtuse, but you get back to sort of economic signaling and the degree to which information flows back and resolves the market from an entrepreneurship side. If you go back to like Hayek, it's like, hey, there's enough information in the marketplace to cause the market to adapt in a more rapid time frame because of the ability for policy to coordinate.
Right. I mean, maybe we should be doing something like a sort of an X Prize approach of, hey, we're going to give away 10 $1 billion prizes for things that can move the needle by 10% on detection and isolation of infectious people.
Or even techniques to reduce some of the, if you were to take some of these policy things and make them smaller prizes or just smaller episodes where people, for whatever reason, whatever the payoff is, that they act in a more responsive way to sort of say, here's the problem that's being observed. We have a quick answer, right? I mean, a lot of times I've been in factory environments where we sat in central command trying to figure out how to do something, and the foreman figured it out in half a second, and it didn't matter how many MIT people you put on it.
Yep.
A certain amount of knowledge lockup in the market. But anyway, I think we'll take a couple more, even maybe one or two more questions. We're going to ask more at the end, but I wanted to give you a chance to sort of cover his part. And we've been running a bit. It's very interesting. But
next, open up to Chris Owen.
Hi, Chris Dunn here, innovation consultant in the food and beverage industry and also angel investor. Carter, thanks for taking the initiative. This is highly appreciated. And Tom, a really enlightening presentation, sobering on the one side, but I think also quite positive and optimistic in being able to identify where we can make the biggest impact. A question on the model that I have, Tom, is does your model take into account now that originally we thought it's mainly the 60 plus and people with underlying diseases or conditions that are higher risk, but it seems now also that the younger population seems to have a higher ability to get sick and end up in the hospital. So that's one question. The second question is leaving privacy concerns aside and thinking about the agent model. If we look at the people that have tested positively and we would overlay that with their geolocation data of their iPhone, because today everyone walks around with an iPhone, would that allow us to predict better where the next hotspots are going to turn up?
Good question. So this model's a little agnostic about the young at risk because it disaggregates into two risk categories as opposed to having multiple age categories, each with a different level of risk. So I can't say too much about that specifically, but I think it does have an important implication for this kind of social mobilization piece, which is there was a perception out there at first that if you were young, you didn't have to worry about this, and that's not entirely the case. But I guess at least I have kids. I'm glad it's not hitting the young the way the 1918 flu did. But certainly we need them engaged, if not for their own sakes, for everybody else's. But I haven't upped into this too much to reflect that in a serious way. That's on the to-do list. And remind me your second question, because that was actually
overlaying the geolocation data.
Oh yes, right. And I think that's another effective idea. You know, again, in the spirit of figuring out where the infections are going. I don't know too much about the details of how that has actually worked in China and Korea and places that have done it. So I can't say too much specific about that.
Thanks very much.
Thank you.
Take one more question and then switch over to Eugene, and then we can also circle back on this. And one thing is, we've further up the chat, we've created an online Slack group that will take any of the other unanswered questions and put them over there, and we can get some answers to some of them in that format. So sign up for that group, and that'll be in the email that goes out sometime this evening to all the participants. But why don't we take one more question on this and switch over to the CPAP conversation.
Last question is from Jaime Alvarez.
Hi, Tom. Thank you for the presentation. I work at National Council of Innovation in Chile. I'm a former controlled systems engineer. And my concern is about the gap between the government and the researchers, and how when the academic community has a forecast that goes away from the business as usual, they're not listened to as closely as they want to. I mean, as you said, you worked with the state and you're helping them make policy decisions right now. Then I would love to hear your thoughts about how to close the gap and build that capacity, maybe not for today, but for future pandemics like this.
Right. I mean, I think it's a tough problem, again, because of this kind of Cassandra's curse problem, that if people listen to you, they solve their problems, and then the problems don't happen, or they're not catastrophic, and so you somehow have to convince people that the counterfactual that might have occurred would have been a disaster, and that's a little bit of a tough road. So there may be something kind of intrinsic in the sort of the evolution of human thinking about these things that makes that hard, but I think we can do better. But doing better probably involves I guess I'm speculating a little here, but maybe a mix of two things. One is kind of doing a better job publicizing the successes that we've had on more mundane forecasting tasks, like the annual flu forecasting, where they're doing pretty well and giving good information to hospitals for capacity planning and things like that. And the other may be to just kind of raise the overall level of debate by improving scientific literacy at all levels.
Yeah, well, definitely it's not an easy problem to
not an easy problem to solve, but interesting. Again, that kind of brings me back to Jay Forrester again, because his last career move was to essentially quit modeling and instead start teaching modeling to kids, so that they understood how these systems worked. So if you have kind of a population that's generally literate about the consequences of exponential growth and delays and nonlinearities in systems, then you have a more receptive audience for someone who notices an emerging problem, to get more attention.
Well, thank you, Tom. Thank you very much.
Great.
Thank you.
So why don't we switch over to Tom, if you can hang on the call, because we may have some more questions. I know you've been at it for a little while here, so we may need a quick break, but I was going to switch over to Eugene.
Yeah, I'll stick around. I want to hear what Eugene's doing too.
Thank you for all your time on this and answers to the questions. I appreciate it.
Well, thanks everybody. It was a great conversation, and I learned some interesting things to follow up as well. So really happy to talk with you all.
Yeah, and part of the intent here is that I know that when in roles like yours, we're trying to figure this out, that there sometimes there are other people like the shop foreman that are seeing some things that are obvious to them, but not maybe to the people trying to do the modeling. So for all the people on the call, the intent here is actually just be bi-directional ultimately, to try to increase perception of what's going on. Eva, or can you stop sharing? I think you need to stop sharing, maybe. Tom, for me to take the screen back. You still there, Tom? Oh, there we
Yeah,
go.
sorry, I was just struggling for the bright red button that says stop sharing.
Yeah, okay. Yeah, I'm not totally used to Zoom yet, but so Eugene, are you there? I assume you are.
Yep. Correct.
So I met Eugene probably now 6 days ago. I got a call out of some folks that were trying to figure out how to 3D print CPAP machines, and I sort of reached out through my network to sort of help them get connected to some designs, and in that process ran across Eugene, who has been involved in this field for some time, well before it existed. More on the EMS side, I actually spent a little bit of time as a EMT in college. So we quickly became friends in this short period of time, but he's been working a lot in the area of CPAPs with Philips, and has had a particular view of how to insert them into the respiratory distress cycle that's going on in the treatment. So with that, I'll turn it over to you, Gene, and why don't you take it from there?
Okay, you're going to throw that slide up for me, please?
Yep.
Let me just do something quick, take advantage of it. Tom, I want to throw a piece of data at you that I just got from one of our Icelandic physicians. Her observation was why is Italy so much different than China? She said in China, the smoking of men was around 50%. Smoking in women was only like about 3%. If you look at Italy, smoking is pretty equal between the sexes. And you may see why there may be a higher death rate in males in China versus females, and an equal death rate in Italy. And so therefore one of the comorbidities could very well be previous heavy smoker, where you've already insulted the lungs and now the virus comes in and adds to the problem. So think about that as something to talk about. We can talk about offline. Anyway, my name is Gene Scarberry. I'm a chemist turn marketer, turn salesman, turn inventor. And I've been involved with critical care medicine and home care and emergency medicine since 1976. I have no formal training in the fields, but my background has been working for people like Medtronic, getting education in cardiovascular work, working in resuscitation, getting into pulmonary work, an inventor of an emergency airway, which got me to work for Philips Respironics, and involved with CPAP from its beginning days. My only claim to fame is that in 1984, I fought with the FDA to get CPAP approved to treat sleep apnea. So what you're about to hear, what's already been printed out, has been transpiring over about the last 2 weeks. This is one of those, again, changing fields. One of my friends from Case Western was working on a paper to send out to existing CPAP patients saying, or BiPAP patients, which is bi-level devices, saying, if you've already got one of these at home, You can continue to use it at night. And oh, by the way, if you become short of breath, you can start using it in the daytime to help you breathe easier. And that triggered some thoughts because of my jaded background, that if I can use positive airway pressure continuously to help prevent the alveoli of the lungs from having infiltrates coming in from the seepage, from the blood flow and the other systems in the body, and so the alveoli remain more effective. If I can utilize bilevel devices to help take over some of the work of breathing. So when a patient goes into a critical care environment, is put on a ventilator and intubated, one of the things that we're accomplishing is the ventilation takes over work of breathing. So that energy that the body would use waste breathing is now available to help the body heal. So if I can take away some work of breathing, that's a worthwhile factor. And then lastly, knowing that somehow this disease also produces in some patients an arteriovenous shunt, where the blood is not perfusing properly around alveoli, moving the body around from back to side to prone, can in fact redistribute air distribution in the correct alveoli. So it's a crazy thought. Also, I'm trying to take where Tom was talking about the hospital overload. If I can take whatever he gives us in terms of the outcome from all of the sequestering and quarantining and say, okay, I've got this amount of people who have got the disease. Can I treat them in home? So not only have them stay at home to fight the disease, but can I give them some support? So if you look at saying, if you're at home and you have a CPAP machine or a bilevel device, use it. If you're at home and you're not a high risk candidate, can I bring a CPAP or BiPAP to you for you to use in home? If I can keep a lot of people out of the hospital, because unfortunately, when you walk through a hospital door, not only are physicians and nurses and great people ready to take care of you, there are also nasty germs that have been homegrown in that hospital. So secondary infections become part of the death process in this patient group. So can I create a triage area for these patients such that if you're at home and whatever you're doing is not helping you enough, I can move you, let's say, to an empty hotel room right next to the hospital, right near the hospital, staff the hotel with people like EMTs or paramedics who have the ability to help care for you, and if you crash, intubate you quickly. Because one of the problems we're seeing is that there's some patients where there's this sort of a linear relationship, and there's some patients where they're falling off the cliff. 1 hour they're looking fine, you're reading a newspaper, doctor comes back in an hour later and they're crashed. So how do I move patients from home to an intermediate area, and then only if you crash do I bring you into the hospital setting? So the beds and the staff are the true limiting factor, and the ventilators are the true limiting factors. What triggered some of this knee-jerk reaction on my part was watching all of the people saying Tesla and everybody else is going to make ventilators. The problem with a ventilator is once I put a tube down your throat, you become, in a sense, a slug. Everything has to be done around you. So I put the tube down your throat. Now I have to give you some narcotics to knock you down so you don't buck the tube and you don't buck the ventilator. Once I do that, I slow down your metabolism. Not a good thing. Second thing is someone has to come in and suction your trachea to pull secretions out of your body, which you would normally cough out. That means I have a nurse or someone else becoming exposed to your infectious material. Then I have to take care of your urine and your feces. The urine is a catheter, the feces are a diaper. That's a more infection potential spreading. And I'm going to have to move you and change you around again to treat whatever else is going on. So each intubated patient becomes a huge strain on the staff in the hospital. So you can add ventilators and you can add beds. You can't easily add the staff. So what I proposed in the document we sent out was to say, can I create this from a true triage point of view of looking at patients and saying, how do I reduce the load of patients truly going into the hospital? can I create a system where those patients are now treated at the appropriate level of care? Non-invasive ventilation, quote, bi-level devices or CPAP, give me an ability to intervene with the best care at the appropriate level. So the only reason I want you to have an endotracheal tube in place if you are a total train wreck. So I have been working with one of the physicians who's en route right now to go to New York to jump into the fray. He was stuck down in New Zealand because of consulting, and he was working on creating a protocol how to take advantage of the existing bi-level devices and the CPAP devices and apply them more to the triage type mentality or within the hospital, or salvaging some of those machines to put them as, quote, standby ventilators. So if I had you at home, I would then want to say, can I get you the machine? Is there any way we have available to bring you some oxygen to supplement the machine? Because the disease, as the virus attacks the individual lung units, the alveoli, causes several things to happen. One, fluid leaks into the alveoli, flooding the alveoli, and it ceases to exchange gas properly. Secondly, the virus also attacks part of the lung, which makes the gas diffusion going from O2 coming in and CO2 going out more resistive. So it's a double whammy. So I need enough pressure to keep the fluid out, and I need enough active alveoli to maintain ventilation for the patient. So the triage mindset says, I've got a lot of existing hardware out there that we believe can be transitioned from treating sleep apnea, which is what I've been doing since 1985, as well as critical care medicine, and turn those into COVID-19 intermediate salvage devices. So it's like saying, what's the least thing I can do to load the system to keep you out of the hospital? So if I can move you back on the curve of disease and allow your body to heal, I don't have to put you into the hospital to have you heal. The other approach is to say, how do I reduce some of the burden on the hospital staff for co-infections? And remember, the hospital is not full of just COVID-19 patients. You have other people who came in there from trauma, who came in from other reasons. How do I prevent you from infecting them? Because that's a really double down worse situation. So if I can keep all COVID-19 patients in one area, either within the hospital or in a triage area, then I reduce cross-infection occurring within the hospital as well. The appropriate protection for this hospital staff is obviously something we don't have perfect information on. Everybody is going from the masks to actually positive pressure devices for the staff is breathing so that air is leaking around masks that they're wearing to prevent them from inhaling the aerosol. What's going on is what's ironic is approximately, let's say 8 to 10 years ago, the company I worked for, Philips Respironics, created a pandemic circuit to put onto these ventilators so that when the patient was put on, the exhale from the patient was trapped with the bacteria filter. Obviously that pandemic didn't last very long and not that many were built or put aside. But the technology to do that exists. That's a very simple modification that everybody's working scrambling to build a bunch of those. So if I want to use the ventilators, I can use them with these new circuits to treat the patient and not spread aerosol in the region. What's ironic is the existing CPAP devices, BiPAP devices for sleep apnea, the masks allow leakage into the room, but because you've gone through this process, if I sneeze or cough, the aerosol comes out very fine. If I'm just exhaling air, the air that comes out of the mask into the room is very large droplets and drops to the floor in approximately 3 feet. So home use is not a big deal to use the existing product. Triage area, you would like to use it with a pandemic type circuit. Bringing them into the hospital only if you have to intubate them. The problem also is this. Once I put a tube down your throat and you have lung disease, I can't just pull the tube in 3 days. if I've already got damaged lungs due to the virus, you're going to be on that ventilator for 10, 15, 25 days. So you tie up a ventilator and a bed. If I could have prevented some of those, we would win. Now, what I'm proposing is been examined by other medical professionals saying it sounds reasonable, but it's not an approved medical procedure. The boxes were not FDA approved to do this. And we have issues still to resolve. What we've been trying as a subgroup, which is what the document that Carter was kind enough to merge a bunch of random documents into, was to say, can we create a protocol, a best effort document to give to higher level people, someone at medical National Guard groups who are used to triaging, to the military, or someone who can take that role and have a call center where you are at home, you're saying, I'm starting to have breathing difficulties. Someone could talk you through how to modify your CPAP or BiPAP to use it at home to help breathing. Second stage would be, gee, if you have problems, you don't have one at home, but you meet a certain category, we'll see if we can get one of the local home care dealers to bring you one. And then if you start having further trouble, the triage says, you know, we're going to dispatch a transport vehicle to take you into the triage center. And then someone from the triage center who puts a tube down your throat has to move you from the triage into the hospital itself.
And Eugene, do you have a sense of like how many of these devices are out there that can be redeployed in terms of the
There are
inventory on the shelf or ramping up production? Or
well, I can tell you that from what I'm seeing, basically the press releases I'm reading. By the way, I have been an employee at Philips Respironics since 1973, excuse me, 83. And so I put in 37 years with them. So and I retired last spring. But what I'm seeing has been both companies that I know of are going quadrupling their output. There are millions of CPAP devices out there. There's probably a smaller number of bi-level devices. What I'm describing is not unique to one specific manufacturer of these devices. There's two major companies, Respironics and Philips, ResMed and Philips. And then the other two companies, Fisher Paykel and DeVilbiss, are the other players. But between the four companies, there are a lot of boxes out there that can be repurposed to this approach. So I'm open to questions. I'm sorry this is not Tom's presentation was phenomenal. I really enjoyed it and really learned a lot. But this was tried to saying, this is a project I've been working on, scrambling for the last 2 to 3 weeks, and still a work in process.
Yeah, so to add a context to this is, and you see this in entrepreneurial endeavors all the time, this is a whole crowd of people are saying, let's go build a bunch of ventilators. And as you've characterized, putting somebody on a ventilator also means, 3 full-time staff paying attention to you for 20 days. And has its own cascading set of challenges, and that there is some portion of that population that you can delay putting on a ventilator or prevent them from even getting on a ventilator. And if you have to, once they're recovered, you can take them off. So that whole cycle is better, and that you've got this train moving down saying, let's go build ventilators. Meanwhile, there's an application here in which a combination of change of business model, in a sense, as we would say as entrepreneurs, into a new therapy regime, go to home, go to a staging area, 5% of who would have been put on ventilators are now, 95% of people who would have gone on a ventilator now are avoiding going on a ventilator by using, I don't know if it's 95%, we'll pretend for a second, by using the CPAP path. And then in the critical few, then you put them into that situation and treat them in an ICU setting. And so it's a combination of, we have another technology path, it exists, it's hard to get that voice across the horizon into a lot of the decision makers, and some of this has to be tested out, but that it's you having done this for some time, your intuition is it's a reasonable change of process that will cut down the burden on ICUs.
The only thing we can look at, there's one paper, there's a lot of papers on non-invasive ventilation. There's a pediatric paper that said they were able to keep 80% of the kids off of ventilators by doing non-invasive ventilation. So even if we're only able to keep 70% off because this is a nastier virus, and it's a lung attacking virus, it still would be a huge reduction in load going into the hospital.
Yeah. So that, I wouldn't mind opening up the questions, especially if we've got any clinicians on the line to sort of augment this, because you have been working with some clinicians in more of an emergency type setting.
Well, I've got those types, but I also have a fair number. The group of doctors that I had been working with have been pulmonologists, sleep medicine, family practice, and one doctor from Iceland. So we had a European mindset going into some of this conversation.
We have a question from Richard Miller. Richard, if you want to go ahead. Not sure if he's still there.
He's got his hand raised. Don't know where he is. While I wait for him, I'm gonna call on Joe here.
Yeah, sure.
Do you have any thoughts on this? You're my go-to.
Yeah.
Favorite.
No, so, Eugene, I applaud you and the group for what you're doing. The concept to be able to even set up another line of triage before you overwhelm the system would be great. If you think about some of the things that are being developed on the medicinal side, what we call somewhat of an antiquated term, but we used to call pharmacological respirators, these respiratory stimulants, they may work very well in these patients because they're not intubated. And so it'll be able to make them breathe. And that's very important too, particularly if they're laboring. And again, part of it is how you can increase the impact on the system itself. So it's very interesting what you're trying to do.
All I can say is we don't know what the effect is going to be on survival rate, so to speak. But we do know that the alternative is what's happening in Italy. Carter was kind enough to attach to this meeting 4 documents. One of the documents is an interview with the people, the physicians from China and the physicians from Italy. And the reality in Italy was who goes on the ventilator, who doesn't. I only have so many ventilators and I have far more number of patients who could go on. How do I simply decide who gets one? So I really don't want to see us go into rationing. I would rather see us, can we do something smarter and sooner rather than result of that type of very tough decision for any physician.
Yeah, I mean, you're absolutely right. And again, if we could stage this thing out where it is less of maybe it could very well be that we do get some medical treatments that will ease the burden on the lungs itself. And so that, along with your device, might be able to mitigate the burden on the hospitals themselves when it comes to admissions as well. So this is very promising, Carter.
Well, so how do we do you have any perception on how because we're talking about both technology and procedural change, which, I can imagine in an emergency setting, but do you have a sense of how Eugene should proceed to try to get?
Yeah, well, the FDA has just, I think Friday, issued guidance on various types of respirators, ventilators. So I certainly can send you that, Eugene. I work on the data safety monitoring board for GE Healthcare and their anesthesia and ventilators and respiratory group. So we have been watching this very closely. The FDA does have a device breakthrough categorization. And this is another opportunity to speak with them to explore how you might be able to get an accelerated review from them and work with them. But I think reaching out directly to the agency is a good idea, and I think they'd be very receptive.
I think part of the problem we've got is that because of my background, I see this as a continuum. If you've got a physician who primarily practices in critical care and sees some of the worst cases, they're very cautiously reluctant to try to do something at home. They would rather get them into the hospital.
Yeah, you know, so part of this is translational medicine, right? You know, so my background is in anesthesia, critical care, and pain. And from the pain side of things, we don't always wait to get empirical evidence. It's just the way it works, right? Studies are too small. So I think we have to use an adoptive design process. The FDA has pathways that allow for breakthrough and accelerated review. And usually that's going to involve having other individuals weigh in. And, you know, what I've been seeing is that there's, at least with the groups I've been working with, either CDC groups or VA, et cetera, is that they're very open to innovation right now. And they're very open to understanding what the value of that innovation is. They're cautiously optimistic. They don't want to have false promises. They don't want to scare people. They want to have as much evidence as they can to move forward. An example of this is related to a big problem with the PPEs, the personal protective equipment, right?
Yep.
And if you look, and you're speaking about Italy, I've been talking to my colleagues in Italy about this problem and reusing. And if you look, even here in the United States, we're reusing personal protective equipment. We've never really done that before. So I can send all of you a whole bunch of documents just as of today. JAMA did an article today. Department of Health in Florida did an article today about how and when you may have to do that. And so I would say this, Eugene, if you looked at something like that and you think about how you would use yours in some type of algorithm process like they do, whereby they look at crisis versus contingency versus continuance, and see how that treatment may fit in, it could be very helpful. Even if this is adopted in the hospital system before you go on a ventilator. So maybe.
Oh, we lost Joe.
But he was dead on the money. Again, that was why I was talking about a triage pre-hospital. I would prefer to have the non-invasive ventilation done if I can before I put you into the hospital environment. But if you've got an isolated part of the hospital that's not being used, maybe this is where we park all of this COVID patients on NIV and then move them within the hospital into the ICU units.
Can I jump in and ask a question?
Yeah, Paul, go ahead.
I don't know much about CPAP, to be honest with you, but the utility of CPAP is for sleep apnea and upper airway obstruction. How much empirical evidence, not theoretical, but empirical evidence, is there that it increases oxygenation in ARDS or pneumonia or congestive heart failure, anything where alveoli have fluid?
Well, basically, the original use of CPAP in the hospital environment before it went out into the home was to take patients off of a ventilator. So you would transition them from a critical care ventilator, taking over the tidal volume and the oxygenation. And then you would transition them over to CPAP where you still had high oxygen, and you would wean them off. The ability to maintain the dilation, the expansion of the alveoli is important. We have information, for example, patients who are COPD who are at home using oxygen. When we put them on just CPAP, seem to have the same benefit without the oxygen. That was some research I'm aware of. So we know that is not an issue. However, CPAP is not an oxygenation system. It simply improves the alveoli's ability to transfer gases better. So if you had an ideal world in home, I would have a bilevel device with enriched oxygen going into that device, and therefore I would be able to maintain you at a pretty good level. If I then had to move you into the triage area, all that would happen is I would have better monitoring. The problem I have in the home environment is the only 4 signals I have that are easily available to the partner at home or the caregiver at home is heart rate, breath rate, O2 saturation, and blood pressure. Those are 4 things that I can easily monitor in one manner or another in those environments. And those are relatively inexpensive tools for monitoring. So I can track you as your disease progresses or worsens.
Thank you.
There are a couple papers we've got somewhere that talk about just the shift to NIV. This sort of notion of avoiding intubation is, I guess, becoming they're realizing in hospital settings that it's more often the case that they don't need to intubate.
Correct. What the trend has been, originally we went from tubes only to trying face mask on just the weaning of the patient, to the saying, well, gee, if I don't have to put a tube down, I would prefer not to in some patients. And so NIV became more and more popular. And now we're seeing people go from oxygen cannulas to high flow oxygen to non-invasive ventilation to endotracheal tube. The problem with high flow oxygen is the more gas I blow up your nose, the more chance I have of distributing more aerosol in this particular environment.
Yeah. Eva, do we have a couple other questions?
Yes, Richard, you should be unmuted if you want to ask your question now.
Oh, thank you. My name is Richard Miller. I've been an entrepreneur for about 40 years and been involved since 2010 when my father passed away after an operation after he got a virus bacteria with a former executive of Ecolab on all the 6,000 hospitals and JCO on infection control and sanitation and disinfectants. And my partners sell chemicals into the hospital industry and the sanitation and MRSA and C. diff and all those issues that are there. And then we moved that into the agricultural market and sanitation and bacteria specific to the dairy and several others and odor controls and so forth. And so I'm spending all my time up until this pandemic, I guess, on the agricultural models and building food prescription concepts and preventative care concepts and regenerative farming. So I got introduced to iSelect about 3 years ago. But I wanted to make a point for Eugene. One of the things in our recent conversations with the hospital and industry and the channel of distribution, there's been a laxing of requirements because of the shortages of products. And they're testing expired sanitizers to see if a bottle and a pallet passes surveillance of bacteria that might have formed. And if it does show no bacteria, they're releasing that pallet of expired material to be used, and their thought process is it's better than nothing. And the same thing that Joseph mentioned, we're reusing personal protection equipment by spraying hydrogen on N95 masks and so forth. So I've used a CPAP years back, and what you're suggesting to take the pressure off the hospitals and put that into, during this time, it seems to me that with the way that the CDC and the FDA are operating, that it's worth the opportunity to try that to relieve pressure on putting people in the hospital before they really need to be there. So I commend on what you're trying to do, and I think that's a great solution, especially with the vast volume of products that you said are available and knowing what they do.
One of the comments that one of the colleagues made was that New York may in fact be a perfect place to try this, since they're doing things like the Javits Center, turning it into a miniature hospital, using that as a place to do the NIV to start with, see how many patients truly need to be intubated, and then expand that out into the community.
Yeah, New York has some interesting issues. They have ventilators in different parts of the states that aren't being used right now. I grew up in New York, but I live 45 miles from the border, and they're doing a good job, but they also are not utilizing the resources that they have within the state to deploy to New York City. It's just a hot spot, but the hospitals are certainly under stress, and that's a problem. So I think that could be used to alleviate some of the people. And they're opening up some hotels. That could be a perfect example of where they could put patients prior to critical care in hotels to separate them and put them on a CPAP.
Yeah, and I think the other thing too, Richard, to go on that, is that we have to remember that we have human capital issues too. We just don't have enough nurses. We don't have enough doctors. In New York and in Florida, they've asked retired physicians to come and help out, retired nurses, etc. One of the strange things about the Spanish flu in 1918 is that it suffered very much from the shortage of nursing staff, right? And here, even though we have much more nurses than obviously they had per patient back then, we still are having human capital issues. So the opportunity that Gene is talking about might be able to allow for a higher amount of patients per nurse, and that's allows for a lower acuity with these patients, and that may also decrease the burden. So it's not just the equipment, but it's the people who have to manage the patients. And so if it is applicable at home, that's great. But if you have it as a triage opportunity in the hospital, that still presents as a very valuable opportunity from an operational standpoint.
The other point is that as I take the criticality out of the support, letting people like EMTs and paramedics do some of the work, they're routinely now bringing patients into the hospital on CPAP already. So they understand the general concepts of the technology. So I now expand my labor force if we look at this model.
I think that would definitely complement the efforts that are being undertaken, particularly with the shortage in manpower. And like you said, CPAP, is a common name now. 20 years ago, not many people really appreciated it, but now, you see people traveling on planes, they bring their CPAP machine with them. This is a really great idea. And again, if there's any way I could help you, Carter knows, he'll give you my information and see how you can look at a regulatory type of priority.
Thank you.
Next, we're going to open it up to Chris West.
Yeah, thank you for the invite. I'm Chris West with the 0 to 510 Medical Device Accelerator down in Memphis. So I appreciate being on this call today. Fascinating triage suggestion on CPAPs. I wonder, and it was also interesting your observation that the CPAP was originally designed to wean patients off of a vent. I wonder if you have thoughts on application in a COVID environment on the back end. My wife has a distant elderly relative out in Las Vegas who has been on a ventilator, to your point, for I think well over 10 days now, and thankfully he is returning to health. He doesn't need the ventilator very often during the day, maybe 2 or 3 times during the day, but they can't take him off yet. Unfortunately, no one else needs it at this point. But I can imagine in a scarce environment setting, it's not just how many ventilators do you have and how many patients need them, it's how many days are those things tied up. So is there a scenario you can imagine on the back end where CPAP is used to wean patients off of ventilators to free up those ventilators for people who are acutely ill?
Definitely. The non-invasive ventilation would be the transition. You would go from an endotracheal tube down your throat to a full face mask covering both your nose and your mouth and on a bilevel device. And then I would slowly reduce the pressures required. The other thing I forgot to mention that I would also throw at Tom to think about is that some of these patients may have in fact have sleep apnea. And that may in fact, every time they go to sleep at night, their body, instead of healing itself, is actually going through a stress test. So if we could somehow tease some of that out, we know that the prevalence of the disease is high. So some of the younger ones that are crashing earlier may in fact have sleep apnea. So looking at the demographics of body weight, neck size, etc., may be another way to tease out some of the who needs this approach or that approach. Since we're dealing with a disease that is, for all intents and purposes, only 2 months old, we're talking about a lot of scrambling so far.
You've definitely given me a lot to chew on, and I think we'll be adding a hospital diversion sector to the model when this state project gets off the ground.
Thank you.
Next, we're going to turn it over to Doug Elliott.
Can you hear me?
Yes.
Hi. So I'd written in a question. I was just curious how easy or hard it is to modify the general CPAP device to allow introduction of adjuvants that might be able to interfere with virus reproduction in the lung tissue once the infections reach there. Did I understand correctly that there are ways of installing exhale filters or treatments so that you can kill or separate viruses from the exhale discharge?
You are correct on the last point. What happens is the circuit going to the patient has a T. Off the T comes a resistance to maintain a certain leak rate. And after that leak rate is a bacteria filter to block that. And regarding your first question, yes, we can administer aerosol into the circuit. Just a second, excuse me. Excuse me, frog in my throat. Yes, we can administer aerosol into the circuit, again, via T approach. And that's being done commonly in the hospitals right now. We haven't migrated that into a home care because not of a need for it, but in this situation, if they find an agent that could be delivered via respiratory path, we can do it. And again, not just us, many manufacturers in this field.
Would that be a more convenient mode of control and application in a home environment?
For the aerosol, no. The aerosol comes with some other issues. So, but the ability to deliver, again, let's talk about the triage location. I could definitely have someone come into the patient, unplug a port, put a aerosol generator into that, have the patient inhale, and use the positive pressure to dilate the lungs, expand them so that they would be open more. So when he takes a breath, he gets a deep breath, and the aerosol could be potentially delivered lower into the alveoli.
So you could basically integrate home healthcare type experts into that, so long as they themselves were relatively protected from casual exposure.
Correct.
Thank you.
Now we're going to turn it over to Matt Bradley.
Oh, thank you. Now I don't have a medical background. I'm a technical consultant. Like I said, I build production lines. And what I was curious about is if there's any other devices, medical or even non-medical devices, that could also be used with as is or with some minimal modification to assist in any area of this. For example, I was thinking like scuba equipment. I don't know if that's a great example or not, but just the first one that occurred to me.
The challenge is this. When I see different people talking about they're going to knock out a ventilator very quickly, the reality of the world is if you accept the approach of saying, I'm going to sedate you and I'm going to give you 12 breaths a minute at a certain tidal volume, the answer is you can build some pretty simple devices that will do that. If on the other hand, I want to leave the patient to spontaneously breathe, which has a lot of clinical benefits, then the algorithm to synchronize the patient to the ventilator is very sophisticated. The problem is a patient spontaneously breathing and inhaling is the ventilator would turn on the pressure. If the face mask the person is wearing is not quite well sealed, that is still forward air moving out of the ventilator, and the ventilator won't shut off. It misinterprets the leak for you asking for a breath still. So time cycle ventilators, or so what it's called, is relatively simple to do. So yes, something could be repurposed. Even animal ventilators in one sense you could think of. But if I want to do spontaneous breathing, it's a more sophisticated environment.
Okay.
Yeah, and there are adaptations now that people are looking at that have been around for a while. You know, based on your curiosity, you can go to YouTube, but there are ways of changing the manifold so you can make one ventilator work for up to 9 people. But it's much like what Eugene said. These are all sort of anecdotal, and there's a big difference when you're taking over the breathing for a patient as opposed to letting them breathe. There's a difference in the entire physiology. So I think that Eugene's got a really unique opportunity there. I'd like to see where you go with that.
Yeah, I was thinking more along the lines of his idea, like the CPAP, using the CPAP device for that, rather than trying to replace the ventilator.
Yeah.
So there, Matt, something that I'm going to go out on an edge here a little bit, but we've both seen it in some of the companies we've looked at, and that you can look at things like pulse rate variability in relation to pulse ox, and understand elements of stress on the body. I've even seen some things where they even can derive fluid level. So for example, if your body's starting to crash to some degree, then your pulse rate variability actually reduces as other parts of your system start taking over and you're under stress. So there's the ability to use, I didn't know if this is where you were going with your questions. I don't think it was, but I'm going to do it anyway since you're a signals guy, is there may be additional ancillary add-ons to a CPAP environment that may help better inform the people monitoring the patient as to how much stressor and what's the vector you're on and what's your rate on that vector that may be of benefit. And I mean, even to the point, and I don't even know if it's possible, but we've seen some of that analysis that lets you understand when you've given too many fluids to a patient in an ICU, which my understanding is can create its own set of problems if you've put too many fluids in them in these kinds of cases. So I don't know if I'm just making this stuff up or whether it all correlates, but in terms of the model about what happens around ARDS, it strikes me that we're going to learn a lot more in this process. Am I out there too far, Joe?
No, not at all. I mean, just remember when you put someone on a ventilator, I think some of the things that Gene was mentioning, people can, if they do attempt to try to breathe on that, they can buck the ventilator. You can have other issues that are associated with it. And you're right, there's a lot to still be learned about this particular, the way this virus is working, what the timeline to fibrosis from those types of buildup of fluids is. These are all things we have to learn. What the effect of, if you notice some of the comorbidities, diabetes and hypertension, particularly people who are on certain antihypertensive medications, and how those medications may be affecting part of your pulmonary immune system, et cetera. So we have an awful lot to learn, Carter. And I think right now, we need to be looking at this very methodically, and we need to be being blue sky with big innovations. And I think the exciting part that I've seen is at least a dozen big non-biotech companies come to the table with really good ideas on how they can help, whether it's on a supply chain issue, a manufacturing, offering their engineers, et cetera. And that's been the creative innovation that has led, I think, to more acceleration. I had mentioned in the chat that we were talking about testing. Well, Abbott announced this afternoon that they have a 5-minute test now. I have to learn more about it, but it evidently was FDA approved from what Bloomberg wrote today. Was on Bloomberg. So that could be very helpful. There's a device that is being looked at, which is generated from MRIs, that can create heat, potentially in your sinuses. and not penetrate into your brain, this dithermy. And we know that this virus is susceptible to heat. So what if you test someone and they're positive but asymptomatic? You know, is there an idea that you should expose them to this, you know, frontal nose and sinus heat? You know, these are all things we're going to find out.
An inductive process?
Yeah, that's it. It's going to be an adaptive process.
Joseph, this is Gene again. There was some research out of Israel basically saying, almost like the old throwback, if you expose the upper sinus to steam, not at ultra high temperature, but anywhere above 105 degrees, and bring that sinus bed to a higher temperature, you would dramatically weaken the virus, so that they actually had a nasal flow device that would put hot steam up into the nose. Now, not hot meaning you can't scald,
Right.
but theoretically, the old wives' tale of sitting there breathing over a kettle of steam, in fact, has actual biological basis for it. I wanted to bring up one other thought. Attached to this presentation, there's 4 references that I asked Carter to include. One of them is a presentation on a group called Ninja Nerd Science by a physician out in Eastern Pennsylvania. He does a superb job of describing how the disease works, and he has a second presentation on the therapies. Both of those are definitely worthwhile if you want to get real detail listening in. He's a little incorrect on some of his ventilator stuff, but other than that, he's really bright. He's got a great teaching ability. And the second one was, there is a link or a reference go to a website called ewtn.com doctor. It happens to be a Catholic website, but there are 2 physicians interviewing a specialist in statistics and epidemiology, and it's a non-political conversation about what's going on. And if you click on the most recent conversation, you'll hear what the latest thought is from a physician point of view, since you can't tie Joseph up for long-time phone calls.
There's one question that sort of bounced through here from Mark Thaler. Eugene, do you have any data yet from COVID patients exhibiting sleep apnea and/or those using CPAP devices?
No, but I know that the epidemiology of the disease is that somewhere between 20% roughly of the US population has some form of sleep disorder breathing. Once you walk into a hospital, if you went into the hospital for any reason, that number jumps to 50. And depending on what area you went into the hospital, your prevalence could be as high as 80%. So we know that sleep apnea is prevalent there. And we know that the comorbidities for the apnea include hypertension, include diabetes, include asthma, include COPD. All of those are highly comorbid to sleep apnea. So I just that was a hypothesis that I had, was that I would expect to find a fair number of prevalence of that disease. So therefore, the bi-level devices would give the patient the ability to breathe better at night, as well as helping them breathe during the day.
All right, so Joe, there have been a lot of conversations about if certain things changed forever. Do you think FDA's approach to approving things has changed forever?
No, but I think, was that to me or to Joseph?
No, go ahead, Gene.
No,
I used to write the 510Ks for our company way back when we were a small company. My experience has been that, unfortunately, the politics seeped into FDA, and depending on which power was in process, the FDA it used to be the FDA was a fair number of scientists working alongside of a company trying to say, what's the best way to help these patients? Then it became the easiest thing for a bureaucrat to say is no. So if you don't have now reams and reams of data to validate your device, the FDA says no. And so therefore the entrepreneurial smaller companies to some degree got pretty well shut out. So Joseph, I'd be interested in your thought process, but I don't think it's going to take a major intervention into the FDA to say what's good science and what's a reasonable cost for that science, versus saying a perfect solution is to make sure that you have 1,000 things, but by the time you get it done, the patients have all died.
Now, Gene, it's not gotten any easier, I'll tell you that. I will say this, just in the last week, guys, they cranked out 4 or 5 new guidance documents that are specifically for COVID-19. So there's at least an effort there. Now, how many of these things will actually result in new technologies? I'm not sure, but with the right to try, with expanded access, which some people call compassionate care, you can leverage all these type of things, and you can try to accelerate the approvals or accelerate the opportunity. I would say this, Gene, check, and I can send it to you, but check what FDA just put out on respirators and ventilators.
Yeah,
and it's amazing. I mean, I've never seen them be so liberal. I mean, they outright say, they're basically saying what you should and shouldn't do, but at the same time, we have to save lives. So where does that all come down in a clearance, a 510K clearance or a PMA? I'm not 100% sure, but I think at least they're trying, and they're inundated. They're all working from home right now. I had a call with FDA just on Thursday. Everyone was working from home, and I have to give you a lot of credit card. Your Zoom works a lot better than the systems that they were using.
So let me ask it another way. What do you think needs to be true for this to cause a permanent change in their?
Yeah, I think that if we have some therapies that from translational medicine standpoint, benchtop to bedside, if some of these things do prove positive, particularly in the diagnostics, I think we're going to see a real acceleration in diagnostics, right? Then this may be a catalyst for potential overhaul. But remember, like anything else, it is a business. They get paid fees when you try to get your drug evaluated or your device.
Yeah.
And there's someone on here who does genetic drug development. They'll tell you what an experience that is, because I've been trying to do that for 20 years as well. So yeah, Carter, I'm cautiously optimistic that there will be lessons learned, particularly because there is more public awareness of where the issues lie when it comes to getting drugs and devices developed. We want to do things very safely, and we want to do it based on empirical data, but we have to also be acceptance of some risk in order to save lives.
Yeah. Well, good. So we've been at this for a lot longer than I thought, but Tom, I wanted to give you a chance to maybe, or Gene, did you still want to say something?
I was just simply saying my aged 77-year-old body is probably saying, I would like to bail out soon.
Yeah, we're going to wrap this up. So, Tom, I think there were one or two questions from this. Did you have anything you want to just add in summary to this conversation?
I think not much more besides what I said earlier, that this has been a really interesting conversation with Eugene, because there are so many kind of alternate pathways to getting the job done that we don't have in the model, and I don't think modelers are talking about them particularly either. So this is something I'll be taking a close look at.
Tom, it's only 4 weeks old.
Yeah.
Well, so, I mean, that to some degree is what this is. I came from Boeing, R&D, control the world, down to entrepreneur land, do a startup in a strip mall and have it successfully grow. And I think the observation on that is that the big processes have an importance, and the ability for an entrepreneur to get close to a problem and solve a problem, if it's Robinson Crusoe trying to get fish, or whether it's trying to solve this problem, they're, both components at certain times are the right components to bring on. So we sort of sat down on Friday and thought about that problem a little bit, and all this noise coming in, and this session that we're having right now, I think, was conceived and put into motion perhaps at 4:00 yesterday afternoon. And we've had upwards to about 90 people on the call through most of the call. It's being simulcast on Facebook. I don't even know if we know how many people are watching there. We tend to get 4 or 5, 10x on those kinds of things when we've done them. So I thank you for everybody's time. We have created an online Slack group, which you'll get an email at some point tonight. I too have to it's been sort of a rush in the last 24 hours. You'll get some more information on that. I wouldn't mind moving some of this dialogue over there. I'm really fascinated about whether it's productive to do some more calls like this on a periodic basis, whether other attendees and other people, to try to connect the Toms and the Eugenes of the world that are sort of operating in different worlds, and use as an opportunity to sort of draw that together. I'm not positive how to do it, but if people who are listening have any ideas on that, please contribute them. I do want to leave a moment, if it happens. I am trying to wrap this up, but I think Flywheel was going to be on the call. There may be any other entrepreneurs on the call that are trying to push some things forward. Flywheel, one of our companies, grabs all the MRI, CAT scan imagery data and properly normalizes it to feed into a lot of the ML and study work. They've opened up their framework for free for any researchers. So anybody that needs to do any type of reconnaissance around MRI, CAT scan, PET scan in and around this disease, if you need access to tools to get that, Flywheel's making those available to researchers for free during this period of time. It's a little bit better than getting free copies of Slack. And then we've got another company that is working on fibrosis, which I think is going to be that's going to be a big problem that we haven't even talked about.
That's
down
right.
the road. Thanks again for anybody. Anybody else out there have something to add? And then Tom and Eugene, thank you very much for your time. Joseph,
It's been fun.
Thanks for
putting this together. It was great.
Anytime, Carter, anytime. Thanks,
Very good.
guys. Be safe.
Bye-bye.
Great. Thanks.
Thank you.